Can everyone hear me? Is that too loud? Hear it in my brain. Alright, so this is the fifth and last discussion for health and homelessness this quarter. Although the class is continuing next quarter, so sad to see the end of this quarter. A couple people emailed me about outreach opportunities. A lot of people have 4 hours, or they were going to volunteer and it was canceled. So there are 2 more opportunities at least. And if you're unable to get any hours by the end of the quarter, we can always give you an incomplete and then give you credit once the hour requirement has been satisfied. So an event, another Teeth and Toes event on December 6th, tentatively. It's kind of tentative. It's going to happen. So that'll be at Roots. The last time we had the Teeth and Toes at Mary's Place. This will be a different venue. Christine Cunningham was the speaker, and she's the executive director at Roots. So it'll be great to interact with her in a different setting and work with that community partner. As always, the Teeth and Toes has, on the teeth side of things, has dental screenings, oral hygiene instruction, fluoride application, and hygiene kit distribution, and then also the foot care clinic will be there. So look for an email from Jackie or myself. And also the training, if you missed the training, I'm editing that, so it should be up on Sunday or Monday, early next week. So it should be up before this tentative date on December 6th. There will be another U-District conversation on homelessness. I actually don't have the date, but it's usually the first or second Monday of each month, meaning it'll be, I actually have the top line's wrong, but on the right there, either December 2nd or December 9th, and those are between 9 and 11:30. I don't have the details on that, but when I do, that will be another opportunity for 2.5 hours of outreach. So if you've done outreach so far, remember to log your hours. And I'd like everyone to complete that and all the makeup exercises by December 11th, so I'm not spending my whole break reading all your wonderful answers and looking at the hour log. And if you missed a discussion session, those are the first, second, and third are posted. The fourth one, the room video, didn't work. I don't think the speaker had the microphone, so there's 0 audio. But luckily, we have someone recording here, so we'll post that one for the last discussion session. And then also, the course is continuing next quarter. You are all welcome to take it. This quarter I had to turn down a few people due to space and the number of outreach hours, so hopefully we will work out exactly how many spots we'll have in the class. But tentatively we'll have Dr. Danielson, who is supposed to be the first speaker this quarter, rescheduled to be the first speaker next quarter, but hopefully he will be there. He'll talk about the social determinants of health. The second discussion session will be Nancy Amadei. She's a former faculty from the School of Social Work, and she is huge in advocacy. And Dental Action Day, which is the dental legislative day, happens to be the day after that, so it'd be a great, warm-up for dental students who want to participate in Dental Action Day and advocate for underserved populations and the like. And then two others that are actually scheduled. Caleb Banton Green, who is in, I'm not actually sure of the department here, works with the White House actually on substance abuse and harm reduction issues. And I've actually seen him talk at the U-District Conversation on Homelessness. He's a great speaker. So he's scheduled on February 6th. Maggie Breen, who we've heard about Reach Center of Hope a few weeks ago, she'll be coming on February 13th and talking about families experiencing homelessness. And then Keegan was kind to talk to someone that he interacted with before coming to dental school that dealt with domestic violence and homelessness. So hopefully that'll be at the end of February. So that's what the schedule is looking like. 5 more discussion sessions. Should be the same requirements. Don't forget to sign in for yourself, not anyone else. So a quick 1 second on intro before I bring Heather up here. Today's talk kind of will be focused a little bit around mental health and homelessness. Just wanted to throw some numbers up there just before she comes. So it looks like, you can see that 20 to 25% of the homeless population suffers from severe mental illness, whereas in the regular general population of Americans, only 6%. So you have a huge disparity there, and is the mental illness leading to homelessness, or is it the other way around, or is it kind of a vicious cycle? And it also is the 3rd largest cause of homelessness for single adults. So thank you for participating this quarter. I've really enjoyed the discussions outside of the class and the questions that everyone's raised. And on that note, I'll introduce Heather Barr, who's a public health nurse at the Healthcare for the Homeless Network in Public Health, Seattle, King County. So,
Thanks for having me come and talk to you today. And I'm so pleased to see the rest of the people who have been presenting to you. Some of them are my heroes, Nancy Amadei, Ben Danielson. They're such great people, and it's a pleasure to be associated with them in this way. So I work for Healthcare for the Homeless Network, and I'm just going to tell you a little bit about what that is. It's a network of providers, and I work in the administrative office, which is housed in the health department. And we pay for the salaries, basically, for a lot of providers who are in the community. And I know you guys have been out to some of the sites where we actually have providers, like at Mary's Place. Some of you went to Mary's Place? How many of you have been out and doing these things out in the community? So Mary's Place serves families and kids, and we have a social worker and public health nurse who have been visiting there and doing intensive case management with families who are most at risk for a plethora of woes, mostly mental health situations and complex social problems. So people who have been homeless for a while, maybe have some CPS involvement with their kids, or who are struggling with barriers to getting housed. You know, some of the barriers to getting housed. Have you talked to people about that? It's just barriers to getting housed for homeless people. What do you think? Name one. Eviction. If you have a history of eviction, it's really hard to get an apartment. Another one is, probably one that we all struggle with, is a credit score. If you don't have a good credit score, it's difficult to get housing, even for people who are homeless. You have to have a credit check done every time you apply for an apartment, and it costs money, and so that can be a vicious cycle and keeps people from getting housed. Any kind of felony conviction can keep you from getting housed or slow the process down if you don't have a case manager. So there's lots of barriers to overcome, and social work is a key element in helping people get housed, which ultimately will help their health. And you guys have probably been noting the linkage between not having a stable place to stay and having poor health, right? Yeah. So what are some of the things that make the homeless population more at risk for chronic diseases and communicable diseases, would you say? Just off the top of your head, what did you notice?
They live in these homeless shelters. They're so confined close to each other, right, that illness easily passes.
Yes, so physical proximity and being in a population that's already risky for diseases, side by each, close up, sharing surfaces and air is a huge issue. So crowding, we could call that crowding. Anything else? Poor hygiene, or very limited access to good hygiene facilities. For instance, just getting to wash your hands on a regular basis can be a challenge for homeless people, right? So if you're homeless downtown and you need to use a restroom, a lot of times you have to pay an admission price, right? You have to buy a latte or something to get in to use the bathroom. And some places are not terribly welcoming to people. So these small things that we take for granted can really put people behind the eight ball in terms of catching a communicable disease or just having the dignity that's associated with being clean. Did you learn something about the hygiene facilities that are available for homeless people in the downtown area? There are a few, but not too many. It is limited at Mary's Place. Union Gospel Mission, did you guys go down to the men's program for Union Gospel Mission? Down in the Reiner Square area? Yeah, they do some hygiene services there. It's very crowded and kind of hard to get into. So yeah, that's a huge one, hygiene. Inability to wash hands. What else do you think?
Poor diet.
Poor diet. What did you notice what the diet looks like in any way?
We have the shelter.
Yeah, what did you notice people eating?
A lot of different things.
Yeah.
High carbs.
High carbs, yeah. A lot of really cheap carbs. and sort of empty calorie food is readily available because purveyors like Starbucks and others are very nice and generous, and they give away their leftover muffins and cookies and things at the end of the day, which is a nice gesture, but sometimes not really the best food for people to be eating. So hard to get are things like fresh fruits and vegetables and complex carbohydrates and protein sources. So people are usually, you can stay fed in Seattle and you can stay, you know, not terribly hungry, but you may be malnourished in Seattle if you're homeless. There are places to get meals, that's for sure, but there's no entity that's kind of making sure that what's served is really supportive and helpful to people, especially people who have chronic diseases. When I say chronic diseases, what pops into your mind first off? Diabetes, right? Diabetes, and what's the twin sister of diabetes? Cardiovascular disease. They're really quite linked. Hypertension and cardiovascular disease and diabetes kind of go together, well, unfortunately. So the diet, once again, not very easy, not very supportive to a low cholesterol, high protein, balanced, complex carbohydrate diet. And that makes people's immune system do what? Your immune system can be impaired by having a poor diet. What else works against your immune system when you're out and about homeless? Sleep. Most people that you talk to will be sleep deprived because they have to sleep a strict sleep schedule if you're in a shelter. And if you're sleeping out, you're vigilant, right? If you're sleeping on a bench outside, unless you're intoxicated or otherwise medicated, you tend to be hypervigilant because you're afraid for being assaulted, which is another health issue that homeless people probably suffer in great disparity to the host population is being assaulted on the street by other homeless people sometimes and by some people who are against homeless people as well. And then people who are just predatory towards people who are more vulnerable. Anything else make homeless people vulnerable to communicable diseases or chronic illnesses that you can think of?
I don't know if this was that, but just poor access to healthcare in general. I don't think it was that.
All right, poor access to healthcare in general. And why would people have trouble with access? Seems kind of obvious, but it's nice to tease this out because there are things that can be ameliorated on that one. Money, not having money, not having insurance. Now we're hopefully getting people enrolled so they can have insurance and have better access. Hopefully there'll be enough providers to actually see people on the other end of it. And not having any money is you know, I saw the social determinants of health up there. You know something about that, right? So money and education are the two things that really are going to determine how good your health is. And homeless people lots of times don't have much in either of those departments. It's kind of unusual because you can run into people who have a PhD and they're homeless. I've met people who had law degrees who were homeless. Kind of ties into that slide about mental health. Anyone can become mentally ill, and a lot of people become homeless because of mental illness. So highly educated people can be represented in the homeless population, but generally the access to education is limited. So poor access can also be linked to mental health in a direct way. You can imagine that. Have you guys worked with patients who had a thought disorder? It's very challenging to work with someone with schizophrenia who is fearful, or they're afraid, and the teeth can be a real big issue with folks. There's been a lot of delusions around teeth stuff. I don't know exactly why that is, but for the longest people thought that they were receiving information from other entities through their fillings. Have you heard of that one? It's kind of a persistent and strange delusion that isn't uncommon. And you know, as technology advances, there's different ways that the technology works into people's delusions. But when people have a persistent delusion around the medical system, they're going to avoid the medical system pretty much. And you can see people really suffering greatly who really need to be seen, but they can't until they have their mental health issue addressed. And getting that addressed can be really challenging because you have to have a trusting relationship with someone just to access that system, which in and of itself can be frightening for people who have been involved in it, especially if they've been in the hospital situation. And if they've had a bad hospitalization, that's going to color their future ability to access the systems are going to be scared. And that scariness, we refer to trauma. Everyone is traumatized. Have you heard of trauma-informed care? Anybody heard the term trauma-informed care? It sounds fancy, but basically what it is that we assume that most people that we deal with who are homeless have endured some kind of trauma, psychological trauma, and physical trauma in their life, which puts them in a category that immediately makes you have to relate to them somewhat differently. And it's more complicated than I'm going to make it for you today, but in the simplest terms, people have suffered a lot, and they deserve to be treated in a way that acknowledges that suffering, and you kind of amend your treatment and your outreach to accommodate that trauma that they've endured. And people's behavior, when they have a behavior that is aberrant or not helping them, at one point in their life it may have been a very helpful behavior. And I'll give you an example in substance use. Substance use could be a very, very helpful thing in the beginning. If you're suffering great pain, something that takes the pain away can be an adaptive thing, right? For a while. People aren't signing up for addiction, but they're thinking, I've tried this drug, my body responds well to it, I feel normal, or I feel calm, or I feel suddenly better because of the drug. People don't use drugs because they don't make them feel better at the beginning. But then the sequelae of using that drug will reveal the trauma of the addiction itself and how people get involved in different activities and behaviors because of the addiction, which are destructive to them. But at one point, you have to kind of acknowledge that did work for the person. And when you can get to that point, you sort of can work on yourself and drop some of the stigma or some of the bias that you may have against an addict when you recognize, at one point in this person's life, that was a functional behavior. If someone's being sexually abused by their family members, which is the closest circle of trust that you have is the people who raise you, and you're being abused that way, you may want to take care of some of those bad feelings, and oftentimes people won't seek out medical providers for that, but they'll find friends who have access to something like an opiate, which is a real great pain reducer, but it is also, as we know, extraordinarily addictive. So if you can think of that, that's kind of extreme drug addiction. How about being a loud person who uses a lot of profanity and seems to always be having a beef with the world? Have you seen that guy? Kind of hard to deal with usually. And I would advise, if you have a person like that as your patient, try to just take a deep breath and recognize that at some point that behavior kept people away from that person. For some reason, keeping people away was a good thing. It's probably become a habit and a way of relating to people that's no longer helpful to them, but they're kind of used to it. I have a guy who I inherited, I'll say. I've been working in this realm for a long, long time, since probably before a lot of you guys were born. But I grew up in a time when we didn't have lots of homelessness. It's unusual to think that there wasn't any homelessness in Seattle, but we really had very little. When I first came on the scene, there was like a couple of shelters downtown. This is like 1983, 84. And the population has swollen over these years due to numerous reasons, and you've probably touched on a lot of them. But I was working downtown. I can't remember what I was doing and what role I was, but there was a guy who was extraordinarily loud and abrasive and frightening to people because he swore a lot and he had this garrulous voice. I can imitate him. He would come in the clinic and say, "I need to go see Dr. Buddha. I got this hand that's bothering me, and I don't know what the fuck is wrong with my hand." And always the fuck word would come popping up. And so people, he'd come up to the desk to get an appointment, and he'd turn him off, right? Because this is not like a pleasant interaction. He's already mad, and people, they're going to take madness personally. There's nothing to be taken personally about this man. He's not really doing that at you, but you can't help but feel kind of like, ugh. So his case manager recognized that I kind of had a tenderness for this guy. I don't even remember how I met him. I think I was doing flu shots or something. And because I was nice to him in my kind of usual nice to everybody way, he sort of made some kind of little bond with me. And his case manager recognized that, and she said, I have to move to New York. Will you please take Douglas? It was kind of like, you know, I watch after my child. I have to go off to the war or something. And I inherited this guy, and he continues to touch base with me. It's not like a formal relationship. He just see me. I do a lot of like walking around downtown. He'd see me, hail me up, ask me for something. I hooked him up with a doctor who he developed a strong bond with at public health, and he also got into the dental clinic down there. And he would come in and do this yelling. You know, that would get you barred from a lot of places, but we understand that this is just how he has had to manage his life, which, you know, after I get to know him a little bit, there's a lot of tragedy there, and I only know the tip of the iceberg. A lot of bad things happen to this gentleman. And he's a short-statured guy, African-American, rather tiny, and I'm sure he's been beat up on a lot. So developing this garrulous voice and just keeping people away was an adaptive behavior for him at one time. So my way of relating to him is just not to do any of that at all. I'm just as sweet as pie and he calls me probably once a week just to check in. I'm just a person in his life that he has identified as safe. He's gotten himself into stable housing with Downtown Emergency Service Center's housing, and he's doing really quite well for himself, taking medications for his mental illness and taking care of his physical health. But it's like, I feel like when he has to go somewhere, I have to explain him to people because of his behavior that can be really off-putting. That's trauma-informed care, when you recognize that the person's behavior was at one time adaptive and you just kind of work around it and don't take it personally. And a lot of our institutions, including parts of the institution that I work with, want to sort of put limits on people, and they call that good boundaries or whatever, and what they're doing is just keeping people out of care. You have to figure out how to help this person calm themselves down and get their needs met without treating them like a child. This man demands absolute respect. So and he's very sensitive if you talk down to him in any kind of way. So most people are, but meeting people in a really respectful way and kind of putting out the hospitality mat in a more rigorous fashion really helps when working with homeless people. We have a security guard at Downtown Public Health who absolutely does trauma-informed care. It's not like something that's been invented, it's just something that now is being standardized. But people recognize that certain behaviors on the part of the care providers are helpful. So now they've codified it, called it trauma-informed care. People have been nice for a long time before this term was coined, and we've been doing it for a long time, but someone had the wherewithal to study it and say, here are some of the things that make for better care for people who are mentally ill or homeless. So this security guard doesn't know she's doing trauma-informed care, but she meets everyone very warmly and graciously and treats people with absolute equity. And the population that she's interfacing with are refugee population and homeless people. People who have absolutely been traumatized, and she's just as warm as can be. And I believe that her behavior is setting the tone for their visit is the most important thing that happens for the client when they get in to see the doctor. The doctor doesn't even know how much work the security guard has done. Then when the person sees the person at the desk, they also have to be warmly regarded there and treated nicely, because a lot of folks have been rejected a lot in their lives, and they will pick up on anything that feels like rejection. Like if the intake clerk is just a little harried and she turns her back abruptly looking for charts, the person might feel a little bit put off by that. So people being aware of their body movements, not being real flagrant with your hands, can be really helpful to try to really create a calm for people to not be triggered by your behaviors. And then when they see you, the provider, some of that groundwork is laid, because that's where the rubber meets the road when they see the people with instruments, right? Instruments and needles and sharp objects that we're coming at them with can be very frightening. And then all around the whole idea of working with people's mouths, have you guys done any research around how that can be a traumatizing thing for people who have sexual abuse histories? So there's anything that's kind of invasive, and when people are put into helpless positions, which, you think about the dental chair, that's a pretty helpless position to be in when you're supine with your mouth open, and you can't really move your arms, and you're sort of harnessed in, and you may have part of your mouth tranquilized, and you can't communicate. That's a very vulnerable position for people to be in. So making it extra calming for those who've been traumatized is really important. Have you noticed that in your work, that people get real trembly around the dentist? It's not just kind of a comedian's joke that visiting the dentist can be a traumatizing thing, but it can be really re-traumatizing for people who have gone through stuff. And you know, that's why you might see a lot of people who are in the shelters who have avoided dental care, really gone to great lengths to avoid it. And one day I was having lunch at a cafe that they used to have downtown that was run by homeless people, and mostly homeless people came there, and it struck me that everyone in the room had a toothache. When the homeless population has so much dental problems that you could pretty much say that everyone was suffering with some kind of malady with their teeth, or they were trying to chew and they were without teeth or missing large numbers of teeth. Anytime you walk into a food line and just notice, you can see right up front their teeth missing, or people who are absolutely in painful conditions that they've kind of gotten inured to because they don't want to deal with it, or they can't get in. It's kind of hard to get into dental care. Healthcare for the Homeless Dental Clinic at Downtown Public Health is just for homeless people. So that's one point of access that they can have. And if they're in pain, they get seen the same day if possible, if not as soon as possible. Have you ever been down there at all to Downtown Public Health? It's an interesting clinic because they do really see just homeless clients. Trauma-informed care, if you can look up and read about that, is linked to another study called the Adverse Childhood Experiences Study. Have you heard of that? That was done by a group of doctors at Kaiser Permanente, and they found that a large number of people had traumatic childhood injuries, and they assigned a score system to that. So people who have a score higher than 4 or 6 are highly traumatized, and homeless people kind of come into that category more so than the general population, but even a lot of people in the general population have endured some kind of childhood experience that was really negative. Separation from a parent going to jail, parent with mental illness, parent with addiction, abandonment, physical, emotional, or sexual abuse, all those things add up to a higher score. The more you have, the higher your score. And the higher your score, they found that they could predict, this is kind of strange, but you could predict chronic disease in people. People who have the highest scores tended to have the most chronic diseases, cardiovascular diseases, and diabetes. And when you think of the link between stress and cardiovascular disease, it kind of makes sense. And then the kind of things people do when they have stress, like overeat on carbs and get themselves into categories for diabetes, you can kind of see that correlation more clearly. But it was a very elegantly done study, and I would recommend that if you can look it up, ACEs, just like the card, ACEs, and trauma-informed care, it can really be helpful for any of your interactions with people, and especially people who are homeless or have been through really rugged situations. So in Healthcare for the Homeless, we really use as part of our philosophy that we do employ trauma-informed care, and that we also employ harm reduction. I heard David mention harm reduction, so you guys are familiar with that concept? Harm reduction? It's helping people do something less harmful. So the most obvious kind of example would be needle exchange. So we have a needle exchange in Seattle, right? You know about that? So people come in and they have a needle that they've used to do injection of some kind of drug, and they can deposit it and they'll get a clean needle in return. Some people say, oh, that's promoting drug use, but in fact we found that it really doesn't promote drug use, it just acknowledges that drug use exists, and we want you to do it in a way that causes less harm. So you're going to harm your body less by using a clean rig. And if we show you how to inject in a way that you don't introduce pathogens to your body, even better, right? So we have a pretty low rate of HIV in King County, because we've had needle exchange for a long time. Early in needle exchange, we encourage people to wash their needle out with, their syringe out with bleach and water. But we found that it did not work for hepatitis B and C very well. So we have very high rates of hepatitis B and C in Seattle, but interestingly, very low rates of HIV in the ejecting population. Other cities don't reflect that, so we're doing something right. And it's better not to have a disease that will affect you for the remainder of your life and you have to take an enormous amount of pills that cost a lot of money, right? So it's a really effective means of protecting people from undue suffering, but it also is an economical move that is quite astute on the part of our government to allow it to happen here. Other states have like said, no, we're not having any needle exchange, we don't have to take care of those kind of people, and we don't want to acknowledge that. Or even just having sharps containers around where people can deposit their used needles in a way that doesn't infect other people is a harm reduction move. Can you think of other types of harm reduction in dental? Doing something that just makes things less bad. They're not going to do the perfect thing, but they're going to do something that may make it less bad. So maybe substituting a different kind of beverage for your carbonated brown soda could be a harm reduction move. People just making a little change can make a big difference in their oral health, right? Maybe brushing your teeth once a day. If you can't do it 3 times a day in the recommended fashion, maybe you can do it just a little bit better than what you're doing now, which might be nothing. So those small incremental changes are harm reduction moves, and sometimes they're as morally conflicting as for some people needle exchange may be, or as benign as just instead of driving around without your seatbelt on, put it on. That's kind of a harm reduction move too. You got to drive, and you're exposing yourself to bad outcomes possibly, because anybody can get an accident, but maybe you won't wreck your head in the accident if you wear a seatbelt. So a little harm reduction is always good to throw into the mix. So we use harm reduction, we use trauma-informed care, and we try to meet people where they are. So we try to do patient-centered care. So those 2 things kind of help us do the third thing, which is really focusing on what the patient's needs are. And a lot of times you can look at a person and say, they have these problems and my agenda would be to take care of these problems, but they may have a very different agenda. You may have a patient who really has a potential amputation that they're looking at, but they may just want to have new socks. So if you don't really get the socks in place, you're probably not going to get to the conversation about what your agenda is. So always making the adjustment where you really listen to what the client is telling you that they need and finding a way, if you can, to meet that one need will help you have better return. And our real thrust in public health is to have people come back. Because you may not be able to do much on the first visit, but you want to make sure that the patient comes back. So all you can do to make that first visit go well is really key. I had a colleague who works through Country Doctor Clinic in Carolyn Downs, who came into the clinic and saw a person who was having a kind of a meltdown, yelling and being obstreperous and causing a little bit of ruckus in the clinic. And so she said, oh, this guy maybe needs a little extra assistance. And she just stepped out of her trod, which was really not involving this person. But she said, it looks like you're having a hard time. Just came up and said, acknowledged that he was having a hard time. And he started to relax, just being acknowledged. Somebody sees me and recognizes that I'm suffering, and she's seeing it. Instead of saying, you can't act like that in here, we're going to call 911 and have you escorted out or something like that. She just said, looks like you're having a hard day. And she was sincere. And then she said, do you want to come sit down over here and would you like a cup of tea? And when you offer people small choices that are really tangible and immediately met, you can really bring down this tension with folks. So offering someone who feels they have very few choices in life is a huge move. Even if that choice is, do you want to use a red pen or a blue pen? Or would you like to sit here or over here? There's things that you can easily employ in your practice that won't harm you at all and gives that person a sense of some mastery over their situation can be really helpful, especially when you're going to introduce them into a situation like I outlined, which was extreme vulnerability. Give him a little bit of choice. So she offered him a cup of tea. He accepted the tea. He accepted sitting in an area where he was a little less triggered by what was going on in the waiting area. And she sat next to him, came back and sat next to him and said, how are you doing? He said, I feel better already. And he was able to discuss. But before that, he was so flooded with his own emotions and his own anxiety that he couldn't deal. So that small gesture, how much does a cup of tea cost, do you reckon? few cents, right? It's basically hot water with some leaves in it. Can't be too expensive. Any clinic can afford some tea and hot water, I reckon. Even people who don't like tea sometimes like to hold a warm cup. So that's a good offer. A glass of water, small thing to us, but for people who don't have access to, good drinking water all day long, it can be a big deal. I used to be a TB nurse, and this is like before they had words like trauma-informed care and harm reduction. We were just kind of polite and respectful and humorous and kind of welcoming. Because we had patients who you had to chuck pills into for 18 months oftentimes. People who really, for the most part, had oppositional defiant type adjustment to the world. You know what I'm talking about? People who maybe had been in prison, or people who were homeless, or chronic alcoholics, and folks who were sort of on the edges of society. And you have to have a relationship with that person because you have to see them at least twice a week for them to take pills. So you can imagine that's a bit challenging. And my whole caseload was people who were either refugee population, which were kind of easier to work with because tended to have stable housing, or homeless people who were sort of mobile and could be found in places like under bridges or in bars at 6 o'clock in the morning, or happy hour for some of those bars is 6 a.m. to 9 a.m., a little bit different on the clock, but there were bars that accommodated the chronic alcoholic person. So, we would roll out the welcome mat and make sure that people took their TB medication because we wanted to protect the general population. And TB medications can wreak havoc on your liver. Alcohol can too, but a lot of my patients wanted to drink their pills down with their alcohol, and we would say, okay, we'll just check your liver and make sure it's all right. That was a harm reduction move. We didn't know it, but that's what that was. And in working with that population, I learned a whole lot about rolling out a welcome mat and making sure people felt recognized as individuals and actually kind of loved. And we would give people birthday presents and Christmas presents. We couldn't say Christmas. We did say Christmas back then. Now we have to say holiday present. But it was something that we just made sure people were felt recognized. They'd come in and they felt known. People would come back after their 18 months were done. We'd hear from them for years sometimes. They'd just come in and check in and say hi. Or I would see them on the street. I got postcards and things from people I'd never would expect to hear from, but would get postcards and little things from people over the years. So it was a very beautiful experience for me because I was probably around you guys' age in my early 20s and had an unusual rapport that I was afforded through my job with a population that I may not have ever really gotten to know had I kept in my little middle-class sphere. And then you work with people who are really from different groups ethnically and racially. When you're working with homeless folks, there's overrepresentation of African Americans and Native Americans. I know my friend Caleb and Jared and his twin brother came and talked to you. Yeah, Caleb's a pretty cool guy. He works at Chief Seattle Club, which is a place that I have worked with since the 80s. And the Native American population is way overrepresented in homelessness. It's like 3% in King County, maybe about, I think it was 14% in homelessness. African American population, 8% in King County. In homelessness, it was closer to 40. That's an egregious, horrible disparity. But in working with populations that you don't normally have to mix with in Seattle, which is a really white town, it's an important thing to gain a lot of comfort and understanding about cross-cultural relationships and anything you can do to know people who are different from you in a deep way is really going to help your practice as you grow up and work with folks, especially if you're going to work in people in poverty and people who are made by our society to be on the outlying edges. What time am I supposed to, now I'm supposed to stop and let you guys ask questions or interact in a different way? You can interrupt me anytime too, I tend to run along. Anybody have any thoughts or, yes ma'am?
What kinds of mental illness do you mostly see?
Depression is probably number one because there's the diagnosed people who are homeless who have a severe mental illness. And that you can see almost anything. You can see the thought disorders. You can see people with mood disorders and bipolar illness for sure. And just general depression, anxiety, GAD, generalized anxiety disorder, post-traumatic stress disorder. I would say that there are a lot of people with undiagnosed post-traumatic stress disorder and a lot of people with undiagnosed depression. The situation can trigger depression, and I think there's somewhere where the situation, if it becomes chronic, that you will develop a chronic depression as well. You can see people really lift and change when they get housing, when their lives get better. Medications can help, but I believe that there's an underlying existential issue, because we get people into housing, and if they don't find meaning in their life, which is the harder thing for people to access most of all, is to really figure out what is my purpose here, and how am I a valid human being, and what is my contribution to life. Homeless people struggle with that and wonder. And people who have had addictions that they've, they can look back and say that their life had a lot of train wrecks in it, and they're trying to put their life together. They can become in a grief state at the wreckage of their own life. So they need a lot of support and understanding around recovery from addiction, but also recovery from the trauma of being homeless. I think we don't do as good a job as we need to assure that folks who, when they move into housing, are getting the support they need to readjust. It's almost like a re-entry program into life, re-entry from prison. And you re-enter from prison situation, you have to put your life back together. When you re-enter life from homelessness, you have to put your life back together. And people do strange things when they move into housing, where they may feel like they don't want to have too much because they know that they're people they know are still suffering and homeless outside. They invite people in to stay over, or maybe they violate some of the housing rules because they're compassionate to others. That can happen to certain cultures. I think Native American people, I've noticed, are very welcoming to other people in their home and have a sense of obligation. But that sense of obligation can get you evicted if you're not following the rules with it. Well, that's a good question. Thank you for that. Yes, sir.
I was just kind of trying to think about how to phrase my question. So when you're working with these people who have mental health problems, are you addressing that with them, or is it more common that it's something that's maybe that they're not aware of?
Sort of half and half. I don't think you come on to people directly and say, "Wow, I noticed that you're really mentally ill." That probably wouldn't work out so good. But it's a good question, because you sometimes have to let people unveil that as they talk, and sometimes you just let people be. Like when people have delusion, it's really not a great idea to challenge their delusion.
I find it more with the recurrent patients, like people that you are treating throughout a period of time. Like you talk about people that you've been in contact with for an extended period of time.
Right.
Are you not only treating their medical condition, like physically, or
You try.
are you working with these people from a psychological?
We try to get people hooked into all the services they need, and really try hard to help people get their mental health issues addressed. Sometimes people will come directly and say, like the other night I was at Nicholsville, and a young man said, "I need a mental health case manager." Just like that, right out the gate, he was just, I had met him a second ago, and he told me that. And so I asked him, where do you go for your physical health? And they can help you get that hookup, or you could go to a day center, and there's a mental health provider there, and I gave him that information. He was very forthcoming. Some people will really push you away and say, "I am not crazy."
Right.
They don't want the label, they don't want to be to come forward with that. They would rather, and they would be saying the most floridly psychotic things to you, but you just kind of roll with it and wait until they're ready to talk about that. So you sort of keep the door open. Yeah, it's important to treat the physical health and the mental health. I don't know why in our country we separate these things out, because we really are just one person. Good question, thank you. Anybody else? Are you looking forward to working with homeless people? Are you enjoying the experiences you're having so far? Do you find yourself looking at yourself differently, or your own privilege in the world? Does it come out in stark comparison? You can feel kind of guilty, and I would encourage you to just examine the guilty feeling that you might have, because it's just a way of informing you about something. But don't take it in and feel bad that you're a bad person, or that, or you're ashamed that you have a car and other people don't have things. That won't really help anything. But if you work somehow toward equity, that will be a real salvo for yourself. And I encourage you to look for ways to make the world a more fair and loving place. And you can always do that by your own behavior in little ways, and you can do that by working in an experience that helps to settle that. And as you become professional, you can always find ways to work towards equity in your workplace too, and call it out. Sometimes people feel really like, oh, I saw this person and I felt so bad and their life is in a shambles and she had these problems and they're so overwhelming, and you can feel really grieved by it too. And just pay attention to your sadness. It's okay to be sad, but understand that that person's life has been going on for a while and that you don't have a responsibility to immediately change everything in that person's life. But you can work towards making sure that if you're, that's your patient, that they're getting the appropriate referrals, and that the clinic that you work in maybe has some ways to address the other needs besides their dental needs. If you're working strictly in a dental entity, there may be other ways to bring other services to that person, or have resources or some social worker, something to help them make the larger framework of their life more tolerable for them. Does that make sense to you guys? Anybody felt those kind of things, like guilty or strange when you're working with folks? Yeah.
I was gonna say, the reason I asked, I've kind of been around it in my family. My aunt is paranoid schizophrenic, and she's had some health problems over like the recent years. And just like watching my mom and dad interact with them, a couple of the programs that they're trying to get involved with required that if a patient were going to be receiving medical care, that they also receive some sort of, counseling psychologically. And when I saw like other people who were involved with that program, a lot of them had a hard time coming to the understanding that they were sick.
Yeah.
And so it was difficult to get these people on the same page and just understanding that, hey, it's okay, like I need treatment in different ways. Some people would push away even getting treatment because they could not accept the fact that they were sick. So
Thank you. It can be really a tricky thing, and one of the ways that we address that is to do motivational interviewing, just talk to people with open-ended sentences. There's some really great videos on YouTube that shows a dental person doing motivational interviewing. Have you guys worked with that at all? It's an incredibly effective skill. Learn it, take a class on it, do something, because it's beautiful. And it helps you really work with what the person wants to address first. And you can gently inquire people, well, how does that work for you? Even a skilled clinician in mental health can get a person who has a delusion to speak about their delusion, which they may feel shame about and may not want to really reveal. I had a colleague who had a client who built this tin structure over her bed, and he just noted that it was there and let her reveal what that meant to her over time. And it turns out that she was feeling like they were rays from outer space were coming in and invading her at night. But if you tease out what the subtext of that story is, she had an incredibly horrible sexual abuse trauma experience, and this nighttime protection was the way she dealt with it. She had a delusion that she had made in order to cope with the terrible thing that happened to her as a child. And 1 in 4 people have had sexual abuse of some kind, so it's not just homeless people, and a lot of us in the room may have had a trauma history too. So I don't want to make it seem like it's an us and them thing, but being aware of how people construct things to make their life more tolerable is really important, and then gently approaching it with an open curiosity that's respectful. That you have to be so gentle, and when you ask people questions, or let them talk to you about it, or say, just that's interesting, you have that tin over the bed, that's interesting, or maybe they'll talk about it next time. But the time factor is huge. And you do have to put in quite a lot of time to build the trust with someone who's paranoid. It's a really difficult thing to deal with. And you do have to allow the person to reveal it as they can. And you want to make people's lives more comfortable. And you may know that this medication will work great, but they may not be ready to receive that at the time. It's a timing thing, and really meeting them where they are, and constantly reaffirming that the relationship is first, that you value them as a human being. And when people get that, they can be more open to the interventions that you may be able to lay out for them. Does that make sense? It's kind of complicated, and yet really it boils down to being kind and letting the person determine the course of their existence, and being there to support their choices when they make those choices, or helping them to look at the choices in a kind of a cost-benefit analysis type way too. What would be good about that? A great question when you want people to shift their behavior, what's good about smoking? What do you like about it? You know, it's like the antithetical thing. You're just supposed to be against smoking, right? But if you ask people, what do you like about it? And let them talk about it, is so much more effective. And then you can say, well, what's negative about smoking? This is what motivational interviewing basically is asking people what's good, what's bad, and what did you ever think about changing, and how ready do you think you are to change, and what would be the barriers to changing that behavior? And in dental, it's a good thing too, because people may have a habit that's sustaining bad teeth, and you can ask them gentle questions about what's good or bad about that behavior. There's something about it that was right for them. And when you acknowledge that, it opens up the conversation. You're no longer oppositional with the person. Is that helpful tips? I hope that it was interesting for you. It was interesting for me to talk with you about this. Enjoy the rest